Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Welcome to CRST, the podcast. I'm George Waring, and today we're continuing the conversation from CRST's March issue on refractive lens exchange and the evolving surgical management of presbyopia. In that issue, contributors explored how surgeons are rethinking the role of the crystalline lens in the refractive practice and how lens-based solutions are being considered for patients seeking greater visual freedom. Joining me today is Dr. Dagny C, who shares her perspective on refractive lens exchange, the patient experience, and how modern workflows are shaping this area of care. Dagny, thanks so much for being with us today.
Hi, George. Thank you so much for having me. It's an honor.
Well, we really enjoyed your contribution to our recent edition for Cataract and Refractive Surgery Today. On the cover story was on the emerging role of refractive lens exchange in our practice. And you were top of mind to contribute on how your practice has evolved over the year and how you're kind of repositioned your practice around this growing patient population. So with that brief introduction, why don't we just ask you a little bit about your background, your practice type, and give us some opening comments on how this is evolving in your practice.
So I practice in private practice in the greater Los Angeles area, and I perform mostly cataract and refractive surgery. I have to say that the majority of my cases is actually leaning more RLE over cataracts these days. And like you said, George, I think refractive lens exchange is just growing exponentially in popularity, just because of patients wanting to live a more active lifestyle sooner and not having to wait till their cataracts mature, as well as just the innovation in technologies and the presbyopia correcting IOLs that we have today. We're just able to offer such better quality of vision today with RLE. And so I'm very privileged to be able to serve this population. I think a lot of people have the misconception that, it's only people who are very educated, willing to pay for procedures like this. They're from the upper class, middle class. But to be honest, I'm very privileged to serve a working class demographic. They're mostly blue collar. They actually depend on, spectacle-free vision to perform their day-to-day jobs. These are carpenters, truck drivers, manual laborers, a lot of them, housekeepers who do a lot for our communities. And it's just an honor to be able to serve them in this respect. So majority of my cases are, 100% pretty much femtosecond laser, and majority are premium IOLs as long as they qualify based on their exam.
So, Danny, that's an interesting prelude into what's sure to be a wonderful discussion. Do you accept medical insurance in your practice, or is it self-pay only for both cataract and refractive lens exchange?
Yeah, that's a great question. So this practice that I took over historically has never taken insurance. So we are all cash pay. So it's just given me very good experience with working in a cash pay environment and serving patients with very high expectations. And certainly it's provided a lot of freedom for us to not have the administrative burden working with insurance so that we can really provide our patients with the absolute best care and customer service possible.
It probably allows for a cleaner delineation between the medical necessity of cataract or the motivation for spectacle freedom and vision correction with lens replacement. I imagine there's more of a natural continuum and the lines are less blurred when you remove the demarcation line of Medicare or insurance coverage. Is that a fair assumption?
Yes, I definitely agree with you. Those issues don't come up. I feel like I have more freedom to practice and perform the procedure that I think is best for the patient. And we don't need to get into the nitty-gritties of what insurance will cover or not. And the patients come in already knowing, this is a cash pay practice, and our goal is to get them glasses free. And they're willing, to pay for advanced technology to get them that outcome.
I think that that also really positions you so well to contribute on this topic that is of increasing interest around the country as as lens replacement does become more popular in the office-based setting, and the average age of cataract extraction is 65 these days. So we're doing this younger and younger. But I think when you remove that barrier from have you met your Medicare guideline and insurance or not, it really makes it a much more pure discussion. So let's continue to dive in. Why don't we start a little bit about the your flow, your workup for whether it's RLE or cataract in the office in terms of are you doing this? Are you offering same day surgery as your evaluation, for example? And what does that evaluation look like?
Great question. That's the lot to unpack there. Well, first of all, I do work, as you mentioned, in an office-based surgery suite. I'm very privileged to have the opportunity to perform these surgeries in office, and I think that's a critical component if you're looking to offer same-day cataract or RLE surgery. So, we start the screening process from the beginning over the phone. Our staff is educated to talk to patients about their needs, and the patients will often say over the phone whether they're coming from a long distance and potentially interested in having surgery the same day. And so, in those cases, they'll obviously schedule the patient on a day where we have room on the schedule. Obviously, make sure that I'm in office and that we have the appropriate staff necessary to potentially convert into a same day surgery. And obviously, we'll schedule them earlier in the day, preferably compared to later in the day. And we always have our staff, give the caveat to that. This is all still pending your exam. Assuming everything is normal and the surgeon clears you, then we can go ahead and proceed with that. So, with that in mind, the patient comes in and we do a normal evaluation as we do for our typical RLE and premium cataract workups. And that's usually just a vision check, uncorrected and best corrected, distance and near, just to get their starting point. We look at their glasses, what their habitual RX is, where they're starting from. And in terms of diagnostics, we do OCT of the macula and the optic nerve head to rule out any abnormalities. And that and the topography, we use a pentacam here to check for higher order aberrations. And I would say those are the two key diagnostics that you need to have on screening to see if a patient would qualify for a presbyopia correcting IOL. And then my optometrist will talk to the patient, and he knows exactly what to ask in terms of the patient's, lifestyle, hobbies, work. How much do they drive at night? I have him try to quantify how many minutes per day, how many times per week, just so I know, what their tolerance to nighttime glare or halos might be. And of course, they always are assessing their personality at the same time. And based on that, the optometrist will, give the recommendation of RLE or cataract surgery with a presbyopia correcting IOL. I actually go to a mix and match approach pretty frequently for my younger active RLE population because I do find that having an EDOF in the dominant eye cuts down on the halos and glare compared to having a trifocal in both eyes. So while maintaining still a very high level of spectacle independence. So that's actually my go-to, keeps things very simple for me. And then, if the patient expresses that they are interested in same day surgery, and it seems that they qualify, that's when we'll do the second exam with a biometry measurements or any additional repeat scans. Assuming the dry eye, is properly managed ahead of time too. We don't want to have any active symptoms. We want to have pretty accurate measurements and make sure the surface looks good as well. And then, we'll have the patient sign the consent, take care of the financials with the patient counselor, and then they'll go ahead and do the workup with the dilation. At this time, while the patient's getting dilated, I'm reviewing all of the exams, specifically choosing the IOL power and making sure that we have that in stock. So obviously, you need to make sure that you have a large consignment for to accommodate any of these same day cases. And I pretty much have the entire consignment for my go-to lenses. A couple of specialty lenses I may have to order ahead of time if they're sort of rare powers, but the majority of normal eyes, I would say, we have in stock. And then the patient is, given some sort of oral sedation, and we perform the femtosecond laser, and then on both eyes, and then we take them into the OBS, and we start with the right eye, and then we, clean and drape, reprep the left eye as a complete separate case, and we're able to accomplish both eyes the same day. And I would say the whole process from beginning to end takes maybe about 3 hours from when the consultation first comes in to when they are officially discharged. And that's assuming, pretty good flow throughout with minimal hiccups. So that's a very, high level overview of how I assess these patients and kind of how we get them to same day surgery.
Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Do you market this same day evaluation and procedure? I mean, is this something that's available? Do you describe this on your website and other informational materials? Do referring optometrists, are they aware of that? Or is it simply when a patient calls in and asks for an consultation or they're referred, your front office just inquires if they would be interested?
Mhm. We absolutely should be doing a better job marketing this, and this is sort of part of the next stage. We're opening a new center, and I'll be having a new website, and that's absolutely going to be a featured attribute of our practice that we do offer same day bilateral surgery in office, no IV required, no fasting, because I do think there are a lot of patients now looking specifically for that. I would say in the past 3 months, I had two patients specifically, both looking for a facility that performed office-based surgery, and they found me because they were looking at the MKO melt. So, for those who may not know, the MKO melt was recently approved for oral sedation cataract surgery, and John Berdal's group did a lot of work in that, and so I think they published on that in their website, and so there are quite a few patients reaching out to their practice asking, "Hey, I'm really interested in this MKO melt, this whole concept of doing in-office surgery. I hate needles. I'm terrified of hospital settings. Are there other surgeons in my area who offer this?" And I got two patients referred from their practice in North Dakota, Californians, and they were able to connect me with those patients. So it's definitely top of mind for a lot of patients, and I think something that we should definitely be advertising more as distinguishing, our center from other traditional sort of ASC based centers.
Absolutely. Do is this? Did you start your program with this approach, or did it evolve with the concept of same day consultation and surgery, and even your procedure, simultaneous sequential femto, and then simultaneous sequential lens replacement after the femto? Were you first doing femto lens and then ensure everything's good and femto in the second eye and lens in the second eye? Or give me a little bit of an idea of how you, um, and for those that may be interested in moving in this direction, of which I'm sure there will be great interest in this, give the listenership a little bit of an idea of how you evolved into your practice.
Sure. Yeah, I think there's definitely always an evolution. I think in terms of the surgeon's own individual comfort with these types of procedures, but also in the overall landscape, we have more research showing that bilateral same day surgery is extremely safe and also very accurate. So when we have comparisons of delayed sequential surgery versus immediate sequential same day surgery, we're finding similar safety outcomes, if not more in favor of same day bilateral outcomes because patients are getting oral sedation usually in these cases instead of IV. And so they're actually moving less during surgery. So there's actually less unsafe movement by the patient, as well as, patients rate the experience a lot better. They don't really have that second eye pain that a lot of, delayed sequential patients often complain about. So, I think the safety of this is well established now. And then you want to look at your own outcomes. How accurate are you hitting the refractive target when you're doing both eyes the same day? Obviously, you have to take it to the next level in terms of your targeting and your measurements. And so I did a retrospective review of my own cases. I think maybe over 500 eyes over a 3-year period, same day bilateral trifocal. And we saw that the refractive error we were hitting within half a diopter in 90% of cases. So that's way above average, even for delayed sequential. So I think it's a pretty good outcome to have doing same day bilateral. And I feel that I'm pretty confident having done this many cases to know that I'm going to land on the target that I'm aiming for. And that's typically what we get in both eyes. If they're unusual cases, there are rare circumstances where I'll delay the second eye because they're post refractive or they have extremely long eyes, extremely short eyes. But even then, post refractive, I'm majority of the time doing both eyes same day. And then, of course, you always have the light adjustable lens as well for those really irregular eyes. So that's sort of how I've become comfortable with adopting this protocol today.
To take that one more level, what about your evolution in terms of doing uh, femto, lens, as you describe it, as opposed to femto, lens
So
for the same
I
control?
That's a great question, and it depends on your footprint of your femtosecond laser and how much room you have in the OR, as well as your flow. So, I do use the LensR Ally, which has a wonderfully small footprint, and I think the majority of surgeons are putting that into their OBS next to their phaco. So I think a lot of surgeons are doing femto surgery in the eye or femtophaco and then next eye femtophaco, and you're keeping it completely sterile. For me, I actually still have my LensR Ally outside of the OBS. And that's the only reason I do femto first and then into the room phaco. And I think I do it for that reason, just for the flow. I mean, we're a one room OBS, and I like having the femto on the outside sort of as um, a feeder, but we're not feeding multiple rooms. The idea is that while I have femtoed one patient, that patient's able to go into the OR and get, prepped and draped. And during that time, I'm doing another femto or another 2 or 3 femto and lining them up. So I feel like I'm able to multitask a little bit more efficiently as well because I'm in an OBS. I'm not just doing cataracts back to back. I often have LASIKs mixed in there, pterygia, ICL, and it's all to accommodate the patient's schedule. So because I have such a diverse variety of cases, it's nice to kind of have the femto separate from the OR as well, so I can sort of jump around, so to speak. But yeah, you should just do whatever it makes the most sense for your flow. For me, because I am doing femto, obviously, I'll only continue if both eyes, are completely normal during the femto phase. And then for the phaco part, I'll always start on the easier eye. So if I've got one eye that I know is very, very dense and more difficult, I'll do the easier eye first and then do that more difficult eye, just in case, just to make sure that I'm not stuck with one eye that I'm not able to move on to because the first eye had an issue. But to be honest, knock on wood, I've never had that issue where I could not complete both eyes.
And you touched base on in your article on post refractive eyes. Are are you using intraoperative aberrometry in your OBS or primarily utilizing the advanced post refractive formulas?
Yeah, I really don't think we need intraoperative aberrometry as much these days because our modern day formulas are so good. And I'm mostly using Barrett True K, and I find that that works very well for 98% plus of my cases. I do think that for post myopic refractive eyes, it does push you a little bit myopic sometimes. So I will go a little bit less. I will use the lens that's a little less power with a little less power compared to what's recommended. And these are just small tweaks that you make over time based on your outcomes. And I do keep track of my outcomes. But yeah, I find that the modern day formulas are good enough that we really don't need to use things like intraoperative aberrometry.
But Dagny, this is just wonderful, and I feel like for many, this really represents a glimpse into the future, and you're just the right person to describe it. we really appreciate your time and want to thank you for joining me and for sharing your insights.
Oh, it's an honor. I feel like we could talk so much more about this topic because there's so many nuances and ways to do it. But happy to just share a sneak peek today with you today, George. Thank you so much.
Thank you. We appreciate it. And thank you for listening to CRST, the podcast. Visit CRST today to read the full March cover focus on these emerging concepts around refractive lens exchange and all the wonderful things surrounding this amazing approach to vision care. That is crsttoday.com. Enjoy your day.
For more shows like the one you just listened to, check out the podcast channel on itube.net.